welcome to ATCM, the Emergency Medicine channel. Today we'll be discussing about a respiratory emergency case.
Okay.
A 40-year-old male patient was brought to ER with complaints of right side chest pain and breathlessness since 1 week. Initial 10-second assessment, patient was conscious oriented and was obeying commands, and he was brought into ER with 6 liter O2 via face mask. Primary survey, his airway was patent and he was able to answer in one full sentence even though he was breathless. And there was no hoarseness, stridor or gurgling. Breathing, his respiratory rate was 23 per minute and he was maintaining 99% with 6 liter O2. Chest.
Can you get low respiratory rate when the patient is having respiratory distress? In any condition?
When this patient is going to a impending respiratory failure.
That means arrest.
Impending respiratory
I'm not asking that. Somebody is having respiratory distress. It is not able to breathe.
Central
hypoventilation. Central hypoventilation, okay. One is that. Then
low sensorium.
Low sensorium will not reduce the breath rate. See, somebody is having hypoxemia. Normally they breathe fast. Can you tell some condition where the patient is having low low O2 levels, but he is not able to breathe fast?
Snake.
Why do I should have that? Common things. Pain. That is most important.
Chest trauma.
Chest trauma is okay. That is correct. But oncology patients, that's the one we should always remember. Any oncology patient come with multiple metastases all over the chest wall, they will not be able to breathe. Even when they have hypoxemia, they will not be able to breathe because of pain. Okay. So in that condition, what is the treatment for hypoxemia?
Pain management.
Pain management. So that we should remember. Second thing is muscle weakness due to continuous use of accessory muscles. Somebody is having COPD or asthma, we are giving continuous nebulization. They develop hypokalemia. So in that type of patients, ultimately they develop a slowly reduced breathing effort.
Muscular dystrophy is also.
Muscular dystrophy also, if somebody is having muscular dystrophy who develops pneumonia, they also have myasthenia. They all have similar findings. So muscles are the one which allow you to breathe fast. Okay. So if they have any problem, including chest wall, ribs, muscles, so you have to be very careful.
His chest movements were reduced on the right side, and on auscultation there was absent air entry on the right side, and there was a hyperresonant note also noted. And circulation, his heart rate was 90 per minute and blood pressure was 110/70, and all peripheral pulses were felt equally and bilaterally. Disability, his GCS was 15/15 and pupils were 2 mm reactive. Exposure temperature was 90°F and GRBS was 124. So as a part of adjuncts, since this patient came with the breathlessness and right side chest pain, we and absent air entry on the right side, we immediately asked for an ABG, and simultaneously we did a USG chest, and we also called for an X-ray. USG chest, when we did, there was absent lung sliding on the right side and there was barcode sign on the M mode. That means there was no comet tail seen in the right side, sir. And simultaneously we took an ABG which was showing respiratory alkalosis. And since this patient also had a history of chest pain, we took an ECG. It was showing only normal sinus rhythm, sir. From the
there is no tachycardia also.
No, tachycardia was not there.
No.
So from this itself, we understood it is this patient is having a right side pneumothorax.
Okay. From ultrasound.
We arranged for an ICD that time, and by the time we were
what are the indications for ICD in a case who is having pneumothorax?
ICD, if the patient is unstable, we should go for a ICD. Otherwise, if it is a trauma-related hemothorax or a tension pneumothorax or empyema and malignant pleural effusions and all, we'll have to.
Even without symptoms, a large pneumothorax need to be drained. Okay, so that also we should. That's an elective procedure, but ER it is different.
See, any changes in the trachea position or any neck veins?
This patient, neck veins were prominent, sir, but trachea was central itself.
Okay.
We went ahead since
why neck veins are prominent in pneumothorax?
because of increased intrathoracic pressure.
Okay. What are the other conditions you get similar finding?
Similar findings can be cardiac tamponade.
Cardiac tamponade.
Then that superior vena cava
Superior
obstruction.
vena cava obstruction. What is the main difference between other conditions?
And that also the upper part of the entire, all the neck veins become distended because of the backflow.
Yeah.
Tension in the veins increases.
But one important finding will tell you that it is SVC obstruction from all other conditions.
Respiratory variation.
Respiratory variation.
Obstruction.
There is no pulsations in elevated JVP in SVC obstruction, including respiratory variations. No variation at all. Okay, that means it is fully enlarged and there is no pulsations you are seeing on the JVP, then it is mostly SVC obstruction. But in a condition who is having tension pneumothorax, there also it can have almost similar finding. You may not see any pulsations sometimes. Okay.
Another condition, the pulmonary edema.
Pulmonary edema. Okay.
Then
Severe obstructive airway disease like COPD, asthma, in a terminal stage, if we are not able to treat initially, then patient will have similar findings of pneumothorax.
So whenever plan for endotracheal intubation or positive pressure ventilation, even if it is a non-invasive, better put a decompression first.
Yes.
Then
so ample history. Patient doesn't have any allergies. Patient is not on any medication. Patient is a smoker for last 20 years and he also uses alcohol. And 5 years back he was diagnosed with COPD, but he was not on any treatment for that. Last meal was 12 hours back. This patient event-wise he had right side chest pain since last 1 week and it was during while taking breath or while exerting only he had this pain. Then after that gradually he developed breathlessness and it worsened to NYHA grade 3 breathlessness. And he was taken to an
Normally NIH is it is also
Cardiac.
it is for cardiac, but MRC is for respiratory. But in practice, almost everything is same. But for an MBBS exam, MRC has to be MBBS or MD exam. It has to be mentioned. But practically both are same.
then he was taken to an outside hospital and they took an X-ray. X-ray was showing right side pneumothorax. They had a doubt whether it is a bulle or a pneumothorax.
Okay.
And he was referred here for further management.
Okay.
He doesn't give any history of trauma and he also gives a history of more than 5 kg loss in the last 2 months. No other his fever or anything was there. So we reassessed the patient. On reassessment, patient's heart rate was
How do you clinically rule out bulle? Clinically means X-ray-wise. Bulle and pneumothorax, is it possible?
some changes are there, sir. The thing is, if it is a bulle, it might not exceed one lung, so one low, one zone will not be exceeded.
One low, it will be mostly confined to one low.
And it will be more circular, so the collapsed lung will be seen more concave in shape.
Okay.
Otherwise, in pneumothorax, it will be seen as a wedge-shaped collapse.
Okay. And mediastinal shifting is not very common in bulle. Okay.
And he was referred for further management. And on reassessment, he was tachycardic, heart rate was 105 and blood pressure was 86/60, and he became more tachypneic, but he was maintaining saturation with 6 liter O2 itself. So at present patient is unstable. So and we have already arranged for an
Why
ICU.
patient is unstable? What are the clinical findings tell you that patient is unstable?
Hypotension is there.
Okay.
In this patient, hypotension. Otherwise,
What is the BP?
BP is 86/60 now.
Okay.
Otherwise, we will call a patient with pneumothorax as unstable if this patient is having a heart rate less than 60 or a heart rate more than 120, respiratory rate more than 24, and saturation less than 90%, or if the pneumothorax is associated with any hemothorax, or if this patient is not able to talk in one full sentence. These are the unstable.
so without oxygen on room air, it will check if the oxygen saturation is dropping
No.
or still maintained.
We didn't remove the oxygen.
So is there necessity to give even pneumothorax and need for oxygen if the patient
Yes,
is
sir.
having?
Yes, in pneumothorax we should give oxygen because that will reduce the size of the air and it will help in absorption.
Say replace the air.
Air.
from the
nitrogen
pleural
gas
cavity,
gradient
so
will
it
be
will
low.
be filled with oxygen. Even smaller pneumothorax also, necessarily we can go for oxygenation. Okay.
So we plan.
This is only one condition where oxygen is given in spite of normal saturation. No, like sir told now. Small pneumothorax admitted in what the treatment is, just give oxygen. Okay.
This patient, since the ICD was already arranged, we didn't go for a needle decompression. We
How do
directly
you do
went.
needle decompression?
Needle decompression we will be doing in the fifth intercostal space, just anterior to the mid-axillary line. We will be inserting a large bore needle will be inserted, and with the syringe with 2 cc syringe, I mean with NS, and when free air comes out, we can know it is needle. We usually, after confirming the position, we will be using a 3-way and we will be aspirating out.
Okay. Previous guideline position was.
Second intercostal.
Now they found that this is more better than in the second space putting, but some doctors still prefer to put in the second space itself. What are the complications? Suppose it's a bulle, without knowing when you are putting a needle, what happens?
That itself can cause a bronchopleural fistula.
No, that can produce pneumothorax. So, when you have a doubt like this, you should have everything ready. Then only you should try for a needle decompression, because sometimes you may be inducing pneumothorax in this type of patients. Those who are having large bulle, when you have doubt, like a patient is having large bulle with breathing difficulty due to some other reason, when you are putting a needle, sometimes he can develop pneumothorax. So we should be very careful in such patients.
See, before putting it, better use an ultrasound guide. That's most important. Number 2, see whether there is any liver enlargement if you are going on the right side, and pregnancy nearing term, so that will be pushing the diaphragm also up. So we can go little above.
We planned on putting an ICD. For ICD, we have got the consent from the bystanders. Then we continued the patient on oxygen. Cardiac monitors were connected, and 2 large bore IV cannulas were also placed. And we also arranged the crash cart and everything ready. And drugs we selected was midazolam and ketamine were selected, sir. And ideally, the contraindication for ICD placement is local infection or that skin area, and thrombocytopenia and coagulopathy. But in tension pneumothorax, the treatment is ICD itself. So,
suppose the patient is having a chest trauma, open wound, what do you do? And he is developing tension pneumothorax. Will you put the tube inside?
no, sir. If it is an open pneumothorax, we will be putting a 3-way, and we will be
3-way means?
We will be using a square-shaped aluminum foil or a IV cannula, that plastic thing we'll be using, and we'll be taping on 3 sides, and 1 side will be left open. So whenever the patient occlusive dressing. So whenever this patient tries to take breath, that will close so that the air will not enter inside, and the patient exhale, the air will go out of that. But we will not be placing an ICD through that hole, because that might need surgical intervention and all. So ICD will always be placed in the same 5th intercostal space anterior to the mid.
You want a clean wound. You cannot put it in an infected wound. So infected wound should be treated as an infected wound with all precautions. We have to clear a clean area for your surgical procedure. Otherwise, that area will get infected, and afterwards patient will have more complications.
This patient, after we gave midazolam, 1 mg was given, and we also give ketamine, 1 mg per kg was given, and then we selected ICD. Since it is a pneumothorax, we selected 20 size ICD. In case of pneumothorax, we usually will be taking 16 to 22 size. If it is hemothorax, we will be taking larger size, like 26 to 30. And we were planning to direct it upward, posteriorly and superiorly. We selected the triangle of safety, that is the lateral border of the pectoralis major, anterior border of the latissimus dorsi, the apex as the axilla, and the lower border as the 5th intercostal space, and just above the lower rib we will be going to avoid injury to the neurovascular bleed.
Lower border of the rib.
Upper border of the
Upper border of the lower lip.
So after giving procedural sedation, we have to clean and drape that area. Then we will have to give local anesthetic to the periosteum of the lower rib and the skin around that area. And then we will have to place a transverse incision and like 1 to 2 centimeter size. And then we will have to dissect through the intercostal space, and we will have to puncture the pleura, and then we will have to insert the ICD.
What are the indications for tube thoracostom?
Indication if this patient is having pneumothorax and this patient is unstable. Then otherwise, in case of trauma, tension pneumothorax, massive hemothorax, malignant pleural effusion, empyema, recurrent. So that was placed, and there was adequate bubbling in the drain. So and we directed it posteriorly, and we took a check X-ray, which was showing ICD in position, and the lung also started expanded. That was done, sir. And the complications which we should anticipate is accidental puncture into the lung or injury to the liver, or if it is in the left side, we should anticipate injury to the great vessels and the heart. That also should be anticipated, sir. So that was done for this patient. And if I'll tell the management of a pneumothorax in case of spontaneous pneumothorax. So spontaneous pneumothorax can be primary or secondary. Primary means in a patient without any underlying pulmonary issues. If this patient is developing a pneumothorax, that is primary. So it is usually seen in young males who are tall, thin and all, and sometimes they will be smokers also. So they might be having some small subpleural blood that will be breaking, and it will be causing a spontaneous pneumothorax. Or it will be secondary to any diseases. So some diseases are COPD, asthma, cystic fibrosis and all, or any other interstitial diseases like pulmonary sclerosis and all. Or otherwise, patient might be having some infections like HIV, tuberculosis and
Most common cause in India is TB.
And or it can be because of some malignancy, or one rare possibility is catamenial pneumothorax, like catamenial endometriosis like features. So these are the causes. Whenever we get a patient with pneumothorax, first we will look the patient is stable or unstable. So we already discussed what are the unstable means hypotension, patient will be tachycardic or bradycardic, or patient will be tachypneic, respiratory rate more than 24. Patient might not be able to speak in one full sentence, associated hemothorax will be there, these things will be there. If it is there, patient is unstable, then we will have to directly go for an ICD insertion. Otherwise, if this patient is stable, then we will have to see if it is primary or secondary. If it is secondary, and if the then we will have to look at the size. In the apex, if the size of the pneumothorax is more than 3 cm, and at the hilum if it is more than 2 cm, then that is the definition for a large pneumothorax. Otherwise, if anything less than that is small pneumothorax. So in such conditions, if it is primary and if this patient is having more than 2 cm size at the hilum, and if it is primary, then we can just do a needle aspiration can be done. And in small cases, we can directly give oxygen to the patient, so that will absorb the air that area. But if it is secondary, then we will have to look at the size. If the size is between 1 to 2 cm at the hilum, then we can plan on needle aspiration. But if it is more than 2 cm in secondary cases, we will have to directly go for an ICD placement.
When will you advise CT scan in these patients, pneumothorax? Will you take for all patients?
If we are suspecting an underlying lung disease, and even after the lung expands, if the lung looks diseased, then we will have to proceed.
Somebody you are seeing in X-ray pneumothorax, he is stable. He is stable enough not to put a ICD immediately. When will you ask for a CT scan?
Any structural abnormality is suspecting, or if you're suspecting a pneumomediastinum associated with that.
And if we have a doubt whether it is bulla,
It is that is the most important thing. If you have a doubt whether it is a bulla or pneumothorax, then only you need to take a CT scan to see what is there. Otherwise, other structural abnormalities we will have to take.
So this patient, after inserting the ICD, CT scan was taken, sir, which was showing right side hydropneumothorax with right side consolidation and cavity and tree in bed appearance. So they had a doubt of tuberculosis, and they did a sputum which was showing a sputum 1 plus and gene
Train
expert.
bed is a classical example of TB. Okay. Will you take gene expert from pleural
From that we will not be treating, sir. From the
Normally, pleural effusion alone, gene expert getting positivity is very, very rare. But somebody is having pneumothorax with pleural effusion, there is a high chance of track from the TB patient to the effusion. In that case, you may get. Otherwise, it is very difficult to get a gene expert positive or FP positive from pleural effusion. You have to go for ADA. ADA is the best investigation. But here, CT shows lung lesion.
Whenever we are managing a patient with ICD, we should always remember to keep that ICD channel down, because if we are keeping it up, the air might go in back. So
Below the patient.
below the patient, it should always be placed, and we should always monitor for the bubbling, and the column movement should be monitored. So if it is pneumothorax and if it has completely resolved, the column movement will stop. Then that is the time where we plan on removing.
You want to remove the fluid, there is hydropneumothorax. You want to remove? Why?
Because when we are trying to drain the fluid itself, air will escape. So there is like no separate indication for like hydropneumothorax you're talking
In
about.
normal pleural effusion, if you don't drain, nothing will happen. But in a TB effusion, if you don't drain, ultimately it will be organized and that part will become thickened. So the movement of that lung will be reduced. That's why you see any patient will have fibrothorax. Okay. So TB is one condition we have to treat aggressively, remove the fluid if possible. Then if required, steroid should be given. Otherwise that part will become fibrosed. Patient will have permanent problem because of that. So fluid in TB must be removed before like discharging. Otherwise, naturally, like suppose some patients after starting ATT can see the fluid will be completely disappear. Then they will not have any sequelae. Otherwise, they definitely have fibrothorax.
And in other conditions, if this patient is on ICD, we will be planning on pleurodesis. Not in this case. If this patient is developing a recurrent pneumothorax on the same side, or if this patient is developing a new pneumothorax on the other side, or if this patient is having a scuba diver, or the patient is has a history of traveling by flight and all, in such conditions, we will be planning on pleurodesis to avoid further pneumothorax.
What happened to the patient afterwards?
And this patient was started on, and this patient ICD column movement reduced, and they removed the ICD. And since the gene expert showed TB, he was started on ATTs.
ATT. Okay. Anything else? Started steroids?
No, sir.
What are the indications for steroids in TB?
TB serositis, like pericardial effusion, meningitis is adrenalitis, then in the gonads, that region, and in the choroid tubercle, eye.
Okay. And when there is massive pleural effusion or hydropneumothorax like this, we'll have to give, otherwise patient will have permanent problems. Anything?
What is re-expansion syndrome? When will you get
Expansion pulmonary edema.
Re-expansion pulmonary edema, if this patient is having a massive pleural effusion, or even this
Any
pneumothorax itself,
pneumothorax, pleural effusion, whatever it is.
if more than 1 liter is removed, or whatever air or fluid it may be, this lungs will be going into a pulmonary edema like features.
Why?
Because of the expansion.
Not expansion. The pressure change. See, till then there was pressure inside, positive pressure. Now you are removing it, so it will become a negative pressure again. So it can draw amount of blood to the pulmonary circulation. Patient suddenly develops features of pulmonary edema. How do you treat it?
Management is
Same
same.
thing, sir.
Management is same itself, like positive pressure ventilation and all. But if it is because of an effusion and all, we can reinsert the effusion back into the tube.
We just clamp the pneumothorax this one, so that again air will reaccumulate, patient will become normal. You can start NIV also.
Rapid decompression, it will happen, and bilateral pneumothorax, it will happen. Sometimes they will be using a negative suction also for draining, that will be happening. So you are taking the patient for CT after the drainage tube is in place.
Yes.
What precautions will you take during the
When
transportation?
you shift the patient.
We should always advise the staff that the ICD tube and the collecting system should be below the patient. That is very important. Otherwise, they will have a tendency to keep it on the trolley.
Underwater, the tube
Underwater.
end will be underwater and it should be on hanging down, not on the bed.
And one more thing, most important, never clamp.
Clamp.
See, actually, sometimes they will be, without knowing this basic thing, they make a tendency is to clamp it, never clamp.
How do you remove the tube when the patient improves? What are the precautions you take while removing? Just remove it. Same sir told no. Clamping. Clamp and see whether patient is having reaccumulation of pneumothorax. If after clamping, if the patient is stable, then you can easily remove. So you have to see.
After clamping, after 4 hours, you'll have to
You
wait
have
and
to-
repeat X-ray and see.
So both in pure location and pneumothorax, before removing, you have to check whether patient deteriorates after clamping or not. If there is no deterioration, then you can easily remove.
Suppose the fluid column is not moving. What does it mean?
And any obstruction is there or not?
Any obstruction, okay. See, hemothorax or any clogging
Clog.
fluid that may cause
Or
obstruction.
kinking,
Then
of the, kinking of the tube itself.
kinking,
Position.
Displacement.
displacement. These are all the common things we have to check. Okay.
How is the patient now?
A patient is on ATT, sir. He is better.
Okay. Anything, sir?
Okay.
Thank you.